Hello, everybody. On behalf of Johnson & Johnson, my name is David, and welcome to today's event, The Effects of Thermal Pulsation Therapy on Astigmatism Management in Cataract Surgery. We are very excited to have Dr. Cynthia Matossian joining us this evening from the US. And before we introduce Dr. Matossian, we would like if you could please select one of the following on the screen. And while you do so, I'll orient you to the webinar platform that you see in front of you. There is a question and answer box that you'll see, and please feel free to ask questions at any point during the webinar. Questions will be answered at the end, and questions will be anonymous. There's also a survey button, and we'd like to please ask you if you could complete the survey towards the end of the webinar. There is a test button for those of you who are looking to achieve CME credits, and you can complete the test and fill out and have a certificate that you can save to your computer and print out at the end of the webinar. There's also a small button that says, please contact the J&J rep if you would like more information. And if you would, please send us a little note and somebody will be happy to follow up. At this time, I would like to introduce our speaker, Dr. Cynthia Matossian. She is the founder and medical director of Matossian Eye Associates. And in 2017, Dr. Matossian received the prestigious Ophthalmic World Leaders Visionary Award, which was included in the Ocular Surgery News Premier Surgeon 300 list, which is an elite group of 300 premier refractive and cataract surgeons in the United States. She has also been named one of the top 25 leading women entrepreneurs in New Jersey and one of New Jersey and Pennsylvania's best 50 women in business. Dr. Matossian, we are so happy that you are here with us. Thank you so much, and we look forward to this webinar.
Thank you very much, and greetings from the United States. Thank you for participating in this webinar. It's connecting us all over the world in these very difficult times. So I am thrilled to be starting. Should we start with the polling questions first?
So Dr. Matossian, the polling questions will be registered towards the end, and I think we can take a look at them at the end, if that's okay.
Sure. Then we'll get started. I am not right now seeing the screen on my screen. So let's see where it is. Hold on one moment, please. Okay, there we go. It's a pleasure, as I said, to be with all of you, and we're going to talk about the effects of thermal pulsation on cataract surgery planning. What does that really mean? Well, we know that Meibomian Gland Dysfunction is very, very common. And fortunately, in the past 5, 7, or up to 10 years, we've had a lot of articles discussing the prevalence of MGD, especially in our patients scheduled for cataract surgery. So we as physicians need to look for it because in about 50% of the time, these patients have no symptoms or perhaps don't realize that some of the symptoms they're actually experiencing may be in fact dry eye disease related or MGD related. So we have to know to take the time, look at, and diagnose dry eye disease before proceeding with cataract surgery. Why is that important? It's important because patients need to know that they have two coexisting disease processes. One that is fixable, meaning it's once and done for cataracts, it won't grow back. The other one will require a lifelong treatment of the chronic progressive nature of Meibomian gland dysfunction. especially in this approximately 50% group who is asymptomatic. You have to make believers out of them that indeed they do have a silent disease, just like high cholesterol or high blood pressure, which has no symptoms early on, but of course requires treatment. Otherwise, it can lead to a catastrophic event. So what are the different steps that are available to us right now? We're fortunate in that the ASCRS Cornea Committee has come up with guidelines for us. These guidelines were published not too long ago. And what they are guidelines telling us how to proceed. The first one is to make sure we ask our technicians, or perhaps ourselves, to ask our patients the appropriate questions. Because if we don't ask, we're not going to find out. As I mentioned, some patients don't realize symptoms such as fluctuations in their vision, especially towards the latter part of the afternoon, if their vision gets cloudier, where they're actually force blinking a few times in a row to get a sentence or a paragraph clear in their vision to read easily. Maybe their eyes feel tired. Maybe they're using their artificial tears more often, but they may not realize that these indeed are symptoms of dry eye disease and Meibomian gland dysfunction. So as soon as any of these questions are positive, then our technicians are empowered to go ahead and do some testing. The 3 tests that we do, that I encourage you to do if you have them available in your respective countries, is tear osmolarity, inflammation testing for MMP9, which stands for matrix metalloproteinase 9, and meibography using Lipiscan or Lipiview, both of which are by J&J, Johnson & Johnson. By having these available, then we as eye care physicians can start to put the pieces of the puzzle together. The next recommendation that the ASCRS has recently come up with is LLPP, which stands for lift, look, pull, and push. And it can be in any order that you want. So instead of just going with the slit lamp right to the lens to see if it's ready for cataract surgery or not, take the time and start a little bit more anteriorly. Look at the lids, look at the lid margins, look at the orifices of the Meibomian glands. Press on them a little bit, lift up the upper lid and pull down the lower lid, and look at what's happening on the ocular surface. I'm a believer in using 2 different dyes, a lissamine green and fluorescein. The lissamine green actually helps me see the conjunctival landscape, what's happening there. It's surprising how often I see significant conjunctival staining on the bulbar conjunctiva, as well as at the junction of the mucocutaneous kind of margin on the lid. And that precedes, in many cases, the corneal staining that we see with fluorescein. So I use both vital dyes, lissamine green as well as fluorescein. And then, of course, the next part is the treatment part. Number 1, as I mentioned, which is so important, is to educate the patient. Because if they don't understand that they have a chronic disease, they're not going to be compliant with anything we ask them to do, let alone spend money to get prescription medications or perhaps pay cash in order to undergo some of these procedures like Lipiflow to evacuate the impacted Meibomian glands. The next step is to make sure that they're using a good quality artificial tear. it's surprising how many patients actually don't realize what artificial tears are, as simple as that may be to us. And instead, perhaps they're using their anti-allergy eye drops in lieu of artificial tears, which of course can exacerbate their dry eye disease. If warranted, this is where removing the impacted material from the meibomian glands will really make a difference. Because if meibomian glands are diseased, if the meibum has become so thickened, it's more like mayonnaise or toothpaste instead of a high quality olive oil, it's not going to be able to flow. And of course, it's the blink, the upper and lower lids touching each other, that releases a small amount of the oil onto the surface of the eye to keep that tear film stable. Well, if the meibomian glands are either A, dropped out, or sick, or the meibum itself that is produced by the meibomian glands is so viscous, it's not going to flow. And the only way to get things going is, in addition to other concomitant treatments, is to heat the meibum and then evacuate it through a thermal pulsed system like Lipiflow. If there is inflammation, and often inflammation coexists with meibomian gland dysfunction, then that's when we use the immunomodulators such as cyclosporin, lifitegrast, and at times a short course of a steroid to help us treat and keep that inflammation on the surface under control. And of course, if the situation is more involved, then we may need amniotic membrane drops or a self-retaining amniotic membrane bandage contact lens for a short period of time. And of course, other treatment modalities or surgical procedures if warranted. So it's a stepwise treatment of MGD. Lipiflow is an FDA-approved procedure. It's actually called FDA-cleared procedure because it's a device, and it is done in the office. It takes 12 minutes. I, as a physician, actually place the topical anesthetic drops onto the surface of the patient's eyes and then insert the single-use activators that you see in the lower left-hand corner. These are disposable. We actually open the peel packs in front of the patients so they know that they're sterile, and then we discard them also at the conclusion of the procedure in front of the patients so that they know they're not being reused. I don't stay in the room for the 12-minute duration. After I insert them, I leave the room and the technician stays with the patient the entire 12 minutes. We never abandon the patient with both eyes, of course, closed with an activator in each eye. And during this time, the patient is a perfect captive audience for education. This is where our technicians spend time educating our patients about MGD, about dry eye disease, about the importance of continuing whatever treatments that we recommend, and letting them know that Lipiflow is not a once and done procedure. Instead, it's something that we have to do on a regular basis, perhaps once a year or once every 18 months, depending on the severity of the Meibomian gland disease and the quality and quantity of the meibum of each patient. The nice thing about Lipiflow is that there's no downtime. Once it's done, the activators come out. We recommend blink exercises for our patients where they actually forcefully blink a few times a day, and then they can actually leave the office, get in their cars, or if they choose public transportation, take a subway or a bus, ride a bicycle, and get back to their normal activities. That's the beauty of it. There is no slowing or interference of their daily activities. Lipiflow is an extremely safe procedure. Hundreds of thousands of these procedures have been performed globally. Perhaps you have units yourselves and you've performed these on your patients. There are many, many peer-reviewed articles written about MGD, Lipiflow, and their effect on stabilizing and optimizing the tear film. We're going to now look at two studies. The first one is not my study, but the second one, which is the next slide, will be my study. This one looked at the impact of Lipiflow pre-cataract surgery on symptoms of dry eye disease. The treated group with Lipiflow is the turquoise one. The control group is the one with a darker blue, navy blue color. And what we can see here is that in the treatment group, the Lipiflow group, their symptoms of dry eye disease post-cataract surgery actually decreased, whereas in the untreated group, the symptoms of dry eye disease increased after cataract surgery. And actually, this is very typical. In our non-treated group, the insult of the surgery and the number of medications that we ask our patients to use perioperatively often exacerbate and worsen the symptoms of dry eye disease. Whereas if we, as eye care surgeons and ophthalmologists, are proactive and treat before cataract surgery, you can see how nicely the symptoms of dry eye disease are reduced. Next, we'll go over my study. And this is a study that I did in our office. I was the only surgeon involved in the study. I had one specific technician work with me, and we used the same pieces of equipment for the entirety of the study. And what was also nice is that J&J did not sponsor this study, so there was no built-in bias whatsoever. So the format of the study was as follows. These were patients, 25 eyes, who had both Meibomian Gland Dysfunction and a visually significant cataract. The agreement had been made to proceed with cataract surgery. I offered them the option to have Lipiflow, and these are patients who paid for the Lipiflow. It was not a gift to them. And what I did is I measured their pre-surgical data prior to Lipiflow, which included keratometry, topography, and biometry with axial length measurements. And then they went ahead and had a Lipiflow done. No other treatments were used during this interim. They came back 6 weeks later, and I repeated the same exact set of studies, meaning with the same technician, the same pieces of equipment. They had their keratometry, topography, and axial length with biometry done. And then I calculated their IOLs twice. Once using their pre-Lipiflow data, and then a second time using their post-Lipiflow data. So we know that most patients have astigmatism, and this is the patients scheduled or undergoing cataract surgery. About 40%, as you can see from this graph, have astigmatism more than half a diopter. And about, another 40% have more than one diopter of astigmatism. So I want you to remember the 40% greater than half a diopter. We'll be coming back to that point shortly. So my patients had the same group of measurements done as we talked about. And then what I wanted to look at was how did I plan astigmatism management differently? How did Lipiflow prior to measurements impact my astigmatism decisions? For the purpose of the study, I said anybody who had less than half a diopter of astigmatism, I was not going to treat their astigmatism. Leave that little bit of cylinder alone. Anybody who had between 0.5 diopters and 1 diopter of astigmatism, they were going to get an LRI or limbal relaxing incision. And anybody who had 1 diopter of astigmatism or more was going to get a toric IOL. And then what I wanted to do is look at the refractive outcome at 1 month and compare it to my refractive target and look at how much residual refractive error, especially how much residual astigmatic refractive error there was. How close was I getting to my refractive goal? So what we did is we used an OPD scan, OPD3 topographer, an IOL Master 700 for our keratometry and axial length measurements. And I looked at the amount of change in the Ks, the mean Ks, the change in not just magnitude of Ks, as well as the axis of the Ks, pre-Lipiflow versus post-Lipiflow. And what was really interesting is what I found. So these are the pre-surgical results. We had 25 eyes, about 50-50 mixture of male and female, 52% were female. The average age was a typical U.S. cataract surgery age, about 73, 74. And so prior to Lipiflow, I had calculated that about 60% of patients would not need any astigmatism management, that 20% would need a toric IOL because they had more than 1 diopter of astigmatism, and about 20% needed an LRI. And if you look at that, that's 20% toric, 20% LRI. That's 40% of patients who had more than half a diopter of astigmatism were getting treatment. And this is actually reflective of that graph that we looked at earlier. So when I first looked at the vector analysis, looking at the pre-Lipiflow treatment, which is the red circle, versus the blue circle, which is the post-Lipiflow treatment group, initially it did not look like there was much of a change. But once we started to drill deeper into the data and analyzed it, were we surprised? What we found out that about 25% of patients post-Lipiflow had less astigmatism than pre-treatment. Another 50% had more astigmatism post-Lipiflow than pre-treatment, and about a quarter stayed the same, no change at all. The exact numbers are 24% had less astigmatism, 52% had more astigmatism, and 24% had essentially no change. But it's easiest to remember, quarter had no change, quarter decreased, and half increased. When I tried to see whether there was any way that we could predict which patient would have an increase or a decrease or stay the same, I realized there was no way of being able to predict that. The nice thing was that once I calculated my refractive outcome based on the post-Lipiflow calculations, and of course I used my post-Lipiflow data to calculate my IOLs, and I used that at the time of surgery, I was really pleasantly surprised that the treatment group, the post-Lipiflow group, demonstrated lower residual refractive astigmatism. My mean vectored residual astigmatism in my 25 eyes was 0.12 diopters with the rule. Whereas in the non-treatment group, had I used the pre-Lipiflow data, there would have been about a half a diopter of residual refractive astigmatism. And we know that about half a diopter of astigmatism that's residual definitely impacts the quality of vision perceived by our patients. I know that this slide is busy, so I'm going to spend a little bit of time helping you go over it. What this slide shows is basically the summary of my pilot study. 40% of the time, I changed my treatment plan. In other words, had I used the data pre-Lipiflow, I would have had a different outcome in 40% of patients, whereas looking at my data that I had post-Lipiflow, I changed my surgical plan in 40% of my patients. And I calculate my own IOLs, I calculate my own astigmatism management, and I'm very fastidious about this. So for me, to have a 40% change in my surgical treatment plan was really a surprise. What does that really look like? Well, when you look at that box that you see there, the blue colors represent the 40% change. And I'll help you go through this one row at a time. Initially, in my pre-Lipiflow treatment group, I had 24% of patients who ended up needing an LRI when originally I had thought that they would need no astigmatism management, and an additional 8% of patients who ended up needing a toric IOL where I originally did not think they needed any astigmatism management. So actually, this represented 32% more patients in my original group who ended up needing astigmatism management. Whereas in my original group that I thought who would be candidates for an LRI, only one person ended up not needing an LRI, meaning the amount of astigmatism that they had actually decreased to the point where my original plan for an LRI ended up being no LRI whatsoever. And in my group in whom I had said, okay, this group absolutely needs a toric IOL, meaning they had one diopter or more of astigmatism, only one ended up having less astigmatism. So I went from planning a toric to ending up doing an LRI. So in other words, 40% of the time, I changed my plan. But again, remember that 50% of the time these patients ended up with more astigmatism. So that represents that 32% patients who ended up with an LRI or a toric IOL in the group that I originally had no astigmatism management plan for them at all. And a small percentage of people, that 25%, had less astigmatism post-Lipiflow, and they're the ones that went from either a toric to an LRI or from an LRI to no treatment at all. So you can see the powerful impact that Lipiflow has prior to pre-surgical measurements. Then I looked at my post-surgery at 1 month refractive outcomes. And looking at this grid, you can see that Lipiflow treatment group improved my refractive outcomes. And my residual refractive astigmatism was better, meaning there was less residual refractive astigmatism in the treatment group compared to the no treatment group. So in conclusion, I know that's a lot of data, But in conclusion, I'll try to summarize it for you. The surface of the eye plays such a key role in our measurements. After all, the ocular surface, the tear film, represent about 2/3 of the refractive power of the eye. So it makes sense that we as cataract surgeons have to pay attention to the surface. We have to optimize it and tune it up as best as we know how before we do our measurements. Initially, my thinking was that dry eye and tear film instability actually masked astigmatism, and that by treating it, we would reduce the amount of astigmatism that dry eye caused, in quotes, astigmatism or pseudo-astigmatism. Well, that's only true in 25% of the patients, whereas in 50% of patients, once the surface is optimized and the tear film is stabilized, actually the astigmatism is unmasked and they have an increase in astigmatism. That's the 50% increase, whereas 25% decrease once the tear film is stabilized. There is no way of predicting which way a patient is going to go, whether they're going to have an increase in magnitude or a change in their axis or a decrease in magnitude. Therefore, we have to rely on our better data post-Lipiflow in order to calculate our IOLs and plan our astigmatism management. And lastly, the amount of residual refractive astigmatism was definitely less in the post-Lipiflow group compared to the pre-Lipiflow group. And sometimes I get questions from other colleagues, other cataract surgeons, saying, are patients willing to pay for both a Lipiflow treatment and for an advanced technology implant? My answer is yes, in most patients. Of course, it depends on their financial status, but most patients want the best vision that they can get because they know that they only have one opportunity for this per eye. And at least that's what we want it to be. So most patients are willing to pay for it and want to get the best outcome if it's explained to them in a fashion that they understand. They need time to absorb your explanations, and they need time to financially prepare to pay for these procedures. But very few of my patients said, no, I would rather have a worse outcome. I don't want to wait to have my surface optimized. I'd rather you do my surgery sooner and end up with a worse result. No patient has ever said that to me. So with that, I will conclude my presentation and we'll open it to question and answers. So this is your time to please ask me any and all questions that you have. This way, I'll try my best to answer them for you. Thank you again for your time, and thank you so much for your interest in this topic. Do we have any questions?
Hello, Dr. Matossian. We have a lot of questions coming in, and thank you for that wonderful lecture. Are you able to see any questions on the screen that are coming up?
No, I don't see any questions. It says, I don't see any questions right now at all. So maybe you can ask me the questions one at a time, and I will do my best to answer them.
Absolutely. So here's one question that came in. The question is it necessary to do Lipiflow, or can we give lubricants for 2 to 3 weeks before biometry?
So the question is, can we just use lubricants or do we have to do Lipiflow? That's a great question. Obviously, any means to improve the quality of the tear film and optimize the surface is better than nothing at all. We also know that lubricants temporarily moisturize the surface by adding often just an aqueous component, sometimes depending on the brand of the tear, it's a combination of lipid and an aqueous mixture. But it does not get to the root cause of the dry eye disease. By doing Lipiflow, we're actually treating one of the main causes of dry eye disease, which is the unhealthy Meibomian glands. So cleaning the meibum out, helping those glands pump that oil in a healthier way, will go a longer distance than just adding topical artificial tears. Obviously, if you don't have access to a Lipiflow, you can contact your J&J folks and see if that's possible. If not, using artificial tears is better than no Lipiflow at all. But Lipiflow will get the lipid layer going, which is the most important layer in order to minimize the second layer of the tears, the aqueous layer, from evaporating. Without a thick enough or healthy enough lipid layer, we're not going to be able to maintain a healthy surface.
Wonderful, Dr. Matossian. And this question asks, what formula, IOL calculator, did you use in this pilot study?
I used the Barrett Universal 2. And we used the IOL Master 700.
So this question says, will the patient need to undergo Lipiflow again after surgery?
Again, this is a very, very good question. Meibomian gland disease and dry eye disease are chronic and progressive. Treating them once is good, but I always use the dental hygiene model just because we brush and floss. That may be the equivalent of using artificial tears, maybe taking oral omega supplements, or perhaps using a microwavable heated moisture mask. That's not enough. We still have to go to the dentist and have the dental hygienist do a deep clean a few times a year. So Lipiflow is similar to that. We still need to have the Lipiflow, perhaps once a year, maybe every 18 months or so. Again, depending on the severity of the disease at hand and depending on how well those glands respond to the Lipiflow thermal pulsation treatment. So it is not a once and done treatment. Yes, in order to maintain that crisp vision with either a toric IOL, maybe with a presbyopia correcting IOL, with that trifocal IOL, you're going to need to maintain a pristine or healthy tear film, which in many patients can only be achieved with recurrent treatments with Lipiflow.
This question's asked, Dr. Matossian, why did you evaluate astigmatism 6 weeks after Lipiflow?
So the question is, why did I evaluate astigmatism? Because to me, the surface of the eye is, as we talked about earlier, 2/3 of the refractive power of the refractive surface, the refractive power. So astigmatism plays a key role, as well as spherical measurements. So I actually looked at both the overall spherical power of the IOL as well as astigmatism. And I feel in order to achieve the best possible outcomes with presbyopia correcting implants, we need to get the amount of astigmatism less than half a diopter. Otherwise, even though that implant may be perfectly, beautifully centered and the surgery may have been flawless, and there may be overall spherical refractive power was on target, but if the patient still has a residual astigmatism, the quality of the vision suffers, and these patients will not be happy with a presbyopia correcting IOL. So to me, to get most of my patients as happy as I could with their refractive outcome was to address astigmatism as carefully and as accurately as I could. That's why I wanted to pay attention and focus on nailing that astigmatism management and getting it below half a diopter as often as I could.
So this question here asks, what are your thoughts on combining Lipiflow with a course of IPL given their different mechanisms in MGD management?
So IPL stands for intense pulsed light. Actually, I do a combination of IPL and Lipiflow in many of my patients. However, not in all of my patients. For this study, of course, it was just Lipiflow. But in general, the treatment approach is very different because this disease is so complex that we have to approach it from many different avenues. The Lipiflow heats the meibum and mechanically evacuates the impacted material from the Meibomian glands. Whereas the intense pulsed light uses a xenon arc light and it kills off or closes off the abnormal blood vessels around the Meibomian glands. And these are the abnormal blood vessels that often leak pro-inflammatory mediators. So this way we're attacking the disease by closing off pro-inflammatory mediator leaking blood vessels through the IPL and by mechanically heating, liquefying the meibum and then evacuating the impacted material. IPL and Lipiflow work very, very well together. However, IPL can only be done in patients who have a skin scale of a Fitzpatrick 4 or lighter, meaning that it is not appropriate to do in patients who are heavily pigmented. Therefore, we are limited in whom we can do IPL.
And this question asks, after a Lipiflow treatment, how long should we wait before we conduct cataract surgery?
Typically, I think if you waited 2 to 3 weeks, that's all you really need for the Meibomian glands to start working to their best capability, while you are also perhaps addressing inflammation. If the surface is really irritated, you may consider a short course of a steroid for 2 weeks, let's say. Perhaps you want to start them on an immunomodulator, knowing that they'll continue on that, whereas they'll stop their steroid. And maybe oral omega supplements, maybe a heated moisturized mask, and a good quality artificial tears. So the key is post Lipiflow, you don't have to wait very long. 2 to 3 weeks is all I have found it to be necessary. Bring them back in 2 or 3 weeks, do your measurements, use your post-Lipiflow measurements to calculate your IOLs and your astigmatism management plan, and then take them to surgery.
And the question here asks, why did Lipiflow decrease residual refractive error in your study?
Because Lipiflow helped stabilize the tear film, therefore I was able to get more reliable keratometry, topography, data, which then I used to plug into my Barrett Universal 2 calculator, or of course toric calculator if it was for a toric IOL. Again, that was the Barrett toric calculator. I was able to have more accurate data to plug in. Therefore, my IOL calculations, including my astigmatism management, was more precise. So I ended up with very little residual astigmatism, which of course was my goal, to end up with as little as possible. So it helped me achieve better, more accurate calculations, which then of course led to better refractive outcomes, closer to my refractive target post-cataract surgery.
And Dr. Matossian, this question asks, would you consider Lipiflow a safe and prudent procedure in these times of the COVID-19 pandemic?
Well, we are in very difficult times and unprecedented times. For example, in the United States, no cataract surgery is being performed anywhere in the United States. That's never, ever happened before. Obviously, right now, our offices are closed except to see emergency and urgent eye situations. Even though dry eye can be uncomfortable, it can be irritating, but we are not open to do elective procedures, and Lipiflow will be viewed as an elective procedure. So right now, we would not be permitted to do a Lipiflow procedure in our office. Once we reopen and once we start to get patients through our doors, have patients feel comfortable and safe coming through our doors. And again, I don't know what that landscape is going to look like. I don't know what our reception room will look like going forward. I don't know if we need to allow a lot more space between the chairs in the dilation areas, for example, or testing rooms. So fortunately, we have a separate Lipiflow room in our office, and no other person is ever in there besides the technician and one patient. So we hope to be able to utilize that room one patient at a time, as we've always done. Again, paying exquisite attention to cleanliness and hygiene, even more so now than pre-COVID period. So hopefully we'll be able to get back to doing our Lipiflows and IPLs, but right now we're not doing it during the shutdown period and kind of mandatory times where we can only see emergency eye situations.
And this question asks Dr. Matossian, with what metrics will you choose to treat MGD patients without symptoms before surgery?
It's very important for us as cataract surgeons to look at the surface of the eye, even if the patient is asymptomatic, because we know about 50% of patients have no symptoms. So the matrix I would use is first by diagnosing, and how would we diagnose is by, even if you don't have tear osmolarity or MMP9 testing, use lissamine green, use fluorescein, and your slit lamp. Push and pull on those glands and look at the surface. That will tell you a lot. Depending on what you see and the level of disease you find, then you can customize your treatment plan. You can follow the recent ASCRS algorithm and basically treat early, treat more aggressively so that the disease does not progress as quickly as it would if you don't intervene. It's very similar to treating blood sugar. Now we treat more aggressively. We want that blood sugar under control in order to decrease all the side effects that diabetes has from head to toe. Same with high cholesterol. Primary care doctors are very tuned in. As soon as the cholesterol is elevated, they recommend exercise, diet change, medication in order to prevent heart attacks and strokes. It's the same for eye disease. It's best to look for the disease because, as we know, 50% are asymptomatic. Treat it earlier, sooner, in order to maintain as healthy a gland as possible in order to minimize the dropout so that that patient has a better chance with less symptoms down the road. And the treatment varies. You can start with very basic in terms of oral omega supplements, a heated moisturized mask, a procedural treatment like Lipiflow, where we heat the glands from the inner lid and then evacuate the impacted meibum from the diseased meibomian glands, to IPL, intense pulse light, that we just talked about. It could be punctal plugs once the inflammation is under control. My philosophy is never plug up the eye when there's inflammation present, because then you're going to increase the contact time of the tear film with all of the inflammatory mediators swimming in it on the surface. It's best to plug up the punctum once the inflammation is under control. Prescription pharmacological options are increasing, and we have more options in our pipelines coming down the pipeline. We also have other treatments if warranted. We have Oxervate right now, which is a recombinant nerve growth factor for patients who suffer from neurotrophic keratitis. So we have many, many new wonderful options in our armamentarium to treat the entire complexity of MGD and dry eye disease.
And Dr. Matossian, this question asks, how many diopters of astigmatism can be corrected by Lipiflow?
We've never looked at that, and what our data showed that the magnitude of astigmatism changes. So it's not truly a correction of astigmatism. It's just treating the surface. By treating the surface, we're either decreasing the astigmatism because there's a healthier tear film and a thicker lipid layer, or the amount of astigmatism is becoming unmasked. So Lipiflow is not a device to treat astigmatism. Rather, it's one of the options to help the ocular surface get healthier. And with that, the amount, the magnitude, and the axis of the astigmatism can change. And there's no way of predicting which way it's going to go.
And Dr. Matossian, this question asks, what objective methods besides the breakup time do you use to decide when starting Lipiflow?
I look at the gland orifices by pushing on them just with my thumb or index finger at the slit lamp. There is a device called the Meibomian Gland Evaluator, which comes with the Lipiflow. It's a small gadget that I keep in my pocket. Sometimes I use that as well. I also look at meibography, which we do with Lipiscan or Lipiview, that shows in black and white the architecture of the Meibomian glands. If the glands are very thickened or very abnormal in shape, instead of looking like straight piano keys, black and white, that's what they should look like, skinny, long, black and white piano keys. If they look fat and squatty, broken, curved, or dropped out, maybe they're down to 5 or 10% of the original gland length. So meibography is a great tool to help me see the health of the meibomian glands and to help show it to the patient, because the patients, by looking at it, can very, very easily understand what's going on with their gland health. You don't have to be a scientist or somebody with a lot of education to see the healthy versus an unhealthy meibography image. So looking at those glands, looking at the quality of the meibum, looking at the inspissation rate or clogged orifices, that's how I decide whether they are a good candidate or not for Lipiflow. I personally have a Lipiflow once a year because I want to take care of my own glands. I want to make sure I have healthy meibum for the rest of my life. So even though I fall in that category of being asymptomatic, I still want to do whatever is possible to help my meibomian glands stay healthy. And I recommend the same to my patients. If there is disease, even if they are asymptomatic, I recommend a Lipiflow in order to maintain the health of these glands. We need them for the rest of our lives.
Wonderful. Thank you, Dr. Matossian. I think we have time for just one more question. We're coming up at the end of our hour. And this question just came in. And the question asks, if we have to choose between Lipiflow and IPL, which one will be a better investment for the clinic as well as for the patient?
That's a difficult answer because each one works differently. It's like saying, which one would you choose, salt or pepper? You really need the two to come up with the best approach to dry eye disease and meibomian gland dysfunction as possible. Lipiflow is less physician intensive in the sense that it heats and evacuates the glands. As I mentioned earlier in my presentation, place the activators into the eye and then leave the room. And for the 12 minutes, the technician stays with the patient. IPL, in the two states where I practice, Pennsylvania and New Jersey, especially in Pennsylvania, only a physician is allowed to perform an IPL procedure. So I cannot delegate that to a technician. Consequently, I do both, but in terms of ease of use, the Lipiflow, it's easier to do and it is less physician time intensive compared to the IPL. Now, depending on where you practice, if you can delegate an IPL to a technician, that might be a different story. But for me, you really need both. It's like salt and pepper or oil and vinegar. You need the two to best approach MGD, one from an inflammation point of view and one from a mechanical obstructional point of view.
Well, thank you very much, Dr. Matossian. Once again, we are thrilled to have you join us here in Asia Pacific and joining us from the Asia Pacific region. Thank you so much for being with us. I know it's early on your time, but it's been truly a pleasure.
Thank you very much for inviting me. It's been great having this opportunity with all of you. Thank you to Johnson & Johnson as well, and thank you to you.
Thank you, Dr. Matossian. And for those of you who are still with us, if you're interested in learning more around the product line that Johnson & Johnson has to offer, there is a website that has been launched called Beyond Cataract, and please feel free to visit to learn a little bit more. Thank you, everybody, for being with us here today, and we hope to see you soon.